Thank you everyone for joining us in today's presentation. For those who I have not met, I'm Jimmy Lindura, the Managing Senior Director of Development for the School of Nursing at UC Davis. Our presentation today will focus on the UC Davis Perinatal Origins of Disparities Center, or what we like to call the POD Center. Heart disease is the #1 killer of women, and childbearing women are at increased risk, especially for those who have had an adverse pregnancy outcome and or live in low resource communities. Faculty and trainees at the POD Center are working to reduce the inequities in heart health among childbearing women through education and intervention, aimed at improving biological, psychosocial, and community risk factors. Now, before I get to our presentation today, Associate Dean for Research, Dr. Janice Bell from the Betty Irene Moore School of Nursing would like to say a few words. Dr. Bell is the Western Health Advantage Endowed Chair. In her role as Associate Dean, she provides leadership, guidance, and mentorship and research to faculty, students, and staff in advancing the school's research program, as well as contributes to the development of the next generation of nurse scientists. She also teaches doctoral courses. Dr. Bell.
Thank you so much, Jimmy Lynn, and welcome everybody. Thank you for being here today. I am super excited about today's presentation. The Perinatal Origins of Disparities Center here at the Betty Irene Moore School of Nursing brings together behavioral science and technology research, which is a really innovative combination. The center's goal is to better understand and ultimately to intervene in factors in early life that affect health in later life. The center has specific interest in factors that disproportionately affect people in disadvantaged communities and might help us to understand and eventually address health disparities. This comprehensive focus on early life origins of disparities has the potential also to prevent intergenerational transmission. In other words, from family to generation of poor health and healthcare. So our speaker today, Dr. Leigh Ann Simmons, brings a lot of expertise in this area of research. It's my great pleasure to introduce her to you. She's a professor at the Betty Irene Moore School of Nursing at UC Davis. She's also the co-director of the POD Center, the co-director of the KL2 training program for early career faculty who are researching patient-oriented care, and she directs the HEAL Lab, which stands for Health Equity Across the Lifespan. And then more recently, she became co-PI and directs the T32 Grant Reach Equity, which trains predoctoral students. There is so much synergy in the work that Dr. Simmons does. We are so lucky to have her on our faculty. Thank you, Leigh Ann, for taking the time to join us, and I'm going to turn it over to you.
Thank you so much, Dr. Bell, and thanks everyone for taking time out of your busy schedules to listen today about the work we're doing in the POD Center. So I'm going to just give you a brief overview about the goals of the POD Center and focusing specifically today on heart health or cardiovascular health, which is one of the main areas of focus. And I will share a little bit about some of the projects that we've been working on and some of the outcomes that we've been able to achieve with these projects. So first, just thinking about health equity. So we've really emphasized health equity, not just in the Betty Irene Moore School of Nursing, but as a society, we're recognizing that there are significant disparities across different groups. And when we think about equity, the one thing we often focus on is how do we support each individual, right? And so you can see in this middle picture here that, one person can see the game just fine. One person needs a shorter box and one person needs a taller box to have the same access. What we're seeking is, in fact, justice. We're seeking health justice. And what that means is that we're changing the structures so that everyone has equal access. So we don't necessarily need to provide these individual supports, but we're changing the structural determinants so that you can see now we've moved from this fence you can't see through that requires individual boxes to see the game to now we have a fence that is see-through. And that's really a driving force of what we're doing. We take a lifespan approach. And so while we talk about it as the perinatal origins of disparities, perinatal really being thinking about prenatal, postpartum, the goal and the purpose of that is because we're taking a lifespan approach, which means that what happens to a pregnant person during their pregnancy, and indeed we're even seeing before they become pregnant, that influences the health trajectories of the subsequent generation. And so the offspring to an individual who may be experiencing severe stress, being they're pregnant in a pandemic, for example, most recently pregnant and having limited resources, whether it's socioeconomic or healthcare, that influences the pregnancy, that influences the health outcomes of the infant, child, and eventually that person into adulthood. And we can see very clearly with longitudinal data that heart health in particular is one of those things that's impacted. And I'm going to talk a little bit more about that specifically. So one of the things we aim to do is we aim to function as an interdisciplinary learning lab. And what that means is that we're really trying to understand all of the different multifactorial influences on health trajectories and health disparities across the lifespan. So you can see we're in this graphic here, we're thinking about what's happening at the biologic level, what's happening with the individual, within their family, within their community, and then of course, broader social structures. We are also aiming to really apply interdisciplinary science and technology. So we have vast technology available to us to address health inequities and to move towards health justice. And I think we've really seen how quickly we're able to move. I like to say that the upside of the pandemic was that we really were able to take advantage of some things that we had in place, but there were structural barriers. One of those being, for example, payment for telehealth. But when there was a need, we rose to the occasion. And so we're really trying to do more of that, really push and advance science and technology to address disparities. We're also aiming to increase the proportion of underrepresented minorities in science, medicine, and nursing. And so again, increasing the representation of folks who come from communities that experience health inequities. And then we also really are engaging community. And I'm going to talk a little bit more about that. But this means engaging, educating, empowering families and communities to be part of the solution to the disparities we're seeing. One of the really unique things that we do in the Pod Center is that we make sure we're not working in a vacuum, but we're working on research that meets immediate, interim, and long-term community needs. And we do that through the use of a paid community leadership board. I want to emphasize the word paid. Very often, community members will be engaged, but they will be asked to provide their time, their talents, their expertise, their lived experience at no cost. And when you're working in communities where people have limited resources, that time is time that they may not be able to work or that they may have to pay for childcare. And so we make sure to pay our community leadership board. And we really engage with them. We respond to their needs, we get feedback, we course correct based on the information they give to us, and we make sure that our research aligns with community priorities. So why heart health? The next slide is probably not going to be a surprise, but heart disease is the #1 killer of women in the United States. In fact, it claims more lives than all forms of cancer combined. So while the emphasis here is perinatal pregnancy, postpartum, that tends to affect people who identify as women who are capable of childbearing, heart disease is actually the #1 killer of men as well. And it matters for men because if their pregnancy was complicated by heart disease or risk factors for heart disease, like maternal obesity, gestational diabetes, maybe they were born preterm, then they are at increased risk for poor cardiovascular health in adulthood. I'm not going to go into too deeply into the science in this slide, but what I want you to get from this or glean from this is that pregnancy has been described as a stress test for the body that essentially unmasks underlying vulnerabilities in the cardiovascular system and the metabolic system. So some facts that I reminded myself of, and having had 2 children myself, it makes me feel extra strong. It is energetically equivalent to running a marathon every single day for 40 weeks. The body is operating at 2.2 times the resting metabolic rate. That is the highest capacity that the human body can operate on. And pregnant women, by the end of their pregnancies, they reach the same peak levels of endurance as people who compete in Ironman. So what we see then is that this stress test is providing information about what are the potential risks, whether there are risks in terms of, how the cardiovascular system is functioning. Sometimes even structural risks emerge. But then we have adverse pregnancy outcomes, things like preeclampsia, gestational diabetes, preterm birth, small for gestational age infants. All of these adverse pregnancy outcomes are significantly associated with an increased risk of developing cardiovascular disease later in life. And these negative impacts can lead to things like persistent hypertension. So someone may have entered pregnancy with normal blood pressure, but they had an adverse pregnancy outcome, and they then may exit pregnancy with persistent hypertension that even requires medication in what previously that person would have been kind of labeled as healthy. So, we see this too in women who have otherwise low cardiovascular risk factors. So I think there's an assumption that women who perhaps have higher BMIs, or they enter pregnancy with a chronic disease like high blood pressure, like diabetes, that those are the women who go on to have complications of pregnancies and adverse pregnancy outcomes, but that's actually not necessarily true. And we see it we see these outcomes, these poor outcomes, even in women with otherwise low cardiovascular risk factors when they enter pregnancy. So why do we want to be thinking about cardiovascular disease in particular and its impact on health disparities? So first of all, there are multiple influences that are intergenerationally connected. So of course, there's genetics, right? We inherit genes from our parents, and they can influence our susceptibility to things like cholesterol, blood pressure regulation, blood clotting. So if you have a parent who had heart disease, had cardiovascular disease, you probably have at least some genetic risk for it yourself. The shared environment. So we know that children often adopt lifestyle habits that are similar to parents. That includes diet, exercise, smoking, even how people manage stress. All of these things contribute to increased cardiovascular disease risk. And then again, as we already touched on, maternal influences. So a pregnant person's cardiovascular health during pregnancy has a very strong impact on the infant and then child, adults' future risk for cardiovascular disease. We also know that adverse childhood experiences, which tend to be more common in people who experience health disparities, these are things like abuse, neglect, parental loss, whether that's through death or divorce or abandonment, witnessing domestic violence, witnessing community violence. All of these factors have been shown to increase risk of developing cardiovascular disease in adulthood. And then similarly, low socioeconomic status or income inequalities can have a significant impact on cardiovascular health, because often it means that adults and children miss important preventive screenings because of poor access to healthcare. It often also means that nutrition is not as good. They may not be, moving their bodies because perhaps maybe they live in an unsafe area, or they live out in a rural area where they don't have access to facilities. And so all of these factors influence cardiovascular disease risk later in life. And then we really also need to think about social and structural determinants of health. So these are things like racism, classism, ableism, sexism, heterosexism. So it's like we call them sort of these isms, but these isms rest within the social structures where people live, where people seek care, where people receive care. And so they compound on these other influences like genetics, like health behaviors, like socioeconomic status. And importantly, these factors, these isms have historical and present day influences. So, for example, when we think of people of color, depending on that an individual's background, whether they're Native American, say, or Black or African American, history of colonialism, of slavery, those racist and colonialist actions impact the physiologic response in those individuals who then have offspring, and then they have experiences that compound, then they have offspring, and then those experiences are compounded. And so then we see these intergenerational transmission of risk factors that are embedded in our social structures, which increase risk for cardiovascular disease. So then how does this happen? What are some of the pathways? Well, we see stress and depression are very highly correlated with heart disease. People who have heart disease, cardiovascular disease, they very often report high levels of stress and or depression and even anxiety in some cases. Unhealthy coping behaviors. So sleep, really important. Most people don't get sufficient sleep. Alcohol use, the pandemic is a perfect example. The rise in alcohol use, especially among women, was substantial during the pandemic. And that heavy drinking is associated with cardiovascular disease, physical inactivity, and smoking. And so these are the most common behaviors that people engage in to sort of cope with stress, depression, anxiety. And then related chronic diseases, so cancer, lung disease, stroke, Alzheimer's disease, diabetes, these are all also often found in people who also have cardiovascular disease. So very frequently we see people with what we would say have multiple comorbidities. So they have more than one chronic disease, and that those diseases sort of work in tandem to make outcomes in each of those diseases worse. And then lastly, what we see is chronic inflammation. There is a lot of research being done on the impact of environmental exposures and stress, depression, behaviors on inflammation in the body. And then inflammation is linked to cardiovascular disease. We also, as a result, recognize that in order to really address and prevent and intervene in chronic disease, and specifically heart disease that we're talking about today, it's challenging. And that is because we are trying to address multiple levels at the same time. So the reality is we can't just focus on the individual. We can't just focus on the health system. We really need multi-level interventions to effectively, intervene, to effectively mitigate, poor outcomes for people who already have cardiovascular disease. And so designing, implementing, and evaluating these multi-level interventions is extremely complicated and challenging, and it is also necessary if we're really going to get towards health justice. Thinking about individual and family support. So as we all know, as individuals, we have, families, we are not functioning, we are not operating in a vacuum. I like to think of it sometimes as, you gather on the holidays, and let's say you've been on a journey for weight loss, and then you're in a family setting and people are like, oh, it's Thanksgiving that we just had, or it's a birthday, whatever it is, a celebration, have the seconds, have the extra piece of cake or pie, have that extra glass or two of wine, right? So the people around us impact our ability to engage in health promoting behaviors. Also, the ways in which people in our families and in our social groups understand what is or isn't a problem impact us. So, for example, some people believe that cardiovascular disease is just genetic and there's really not much that you can do about it, when in fact there are strategies. And so, if that's the messaging that you're getting from your social circle, then that may impact how you do or do not say, like, adhere to provider recommendations regarding management. And then community engagement and buy-in is critical. So a lot of the work that we do, we are working with community-based organizations, with federally qualified health centers or public health clinics, who are providing care to patients who don't have health insurance or who are receiving, Medi-Cal for their insurance. And so engaging the community and getting their buy-in to shift the ways in which the system connects, operates, work is extremely challenging. It can be done, and I'm going to talk about how we've done that, but it's extremely challenging. And the other piece of this is really thinking about kind of the role of systems, right? So the systems that we have, the systems of healthcare, the systems of insurance, what it pays for and doesn't pay for, the systems in which these kind of broader systems and structures in which they're operating, right? So we have systems, we have policies. So how do the policies that we have, how do we operationalize those, and how does the system impact the ways in which we operationalize them? Because that's then going to impact the programs and services that we're able to provide. Okay. And so that is a complicated trajectory that has multiple influences on it. And the role, or the goal, excuse me, is integration. So we're really trying to integrate and have these different pieces of the puzzle talking to each other versus operating in a vacuum. So it sounds daunting, and you might be sitting there thinking, well, that just seems like a very large problem that can't be solved or is too complicated to solve. But what I like to think about these complicated systems is that there are many, many opportunities, right? When a system is complicated, when there are many pieces and facets contributing to how that system operates, that means there are as many problems as there are the same number of opportunities. So one of the big opportunities is addressing gaps in care. We know that there are gaps in care for different groups. We know that folks living in rural areas have gaps in care. We know that people who don't have insurance have gaps in care. We know that people who don't have papers have gaps in care. So that is a very clear area for us to address. Timely prevention and early intervention. The earlier we intervene, and which is why we are going back to folks who are pregnant. So we are and even to pre-pregnancy, so people who are planning to get pregnant. The earlier that we can intervene, the better our outcomes are. And so really focusing on that early time frame is what's going to ensure that every person has an equally healthy start in life. Also, screening and referral policies and practices. So how we screen and the things for which we screen and who gets screened, these are all factors that influence somebody's health and well-being. And so we want to make sure that we're being purposeful about who we screen, how we screen them, and then what we do with that information. So let me talk a little bit about how we filled some gaps in care. So as I mentioned, the pandemic, was obviously an extremely traumatic event. You might tell by now I'm an optimist, so I like to think about, well, what were the opportunities that came from that? And I think one of the opportunities that emerged was that people became very comfortable with using telehealth, digital health, basically getting care remotely. That was not something that people were comfortable with, and it was also not something that insurance companies or that Medicare or Medi-Cal paid for. So there was a significant barrier to that. but folks are very comfortable now and it's easy to engage with them. And so this application that we have, and people have developed multiple applications over the last, 10, 15 years to address health issues. We have one in particular that we worked on during the pandemic, and we found that folks had, like, overall, they had gained less weight during pregnancy than what you see in national averages, and they also had retained less postpartum weight than what you see in national averages. And these were people who entered pregnancy with overweight or obesity. So we were able to use digital health. And now we're building on this application to increase activity and to start looking at some of these other biomarkers like blood pressure impacts, like blood sugar, glucose impacts. The other thing we really focused on is prevention and early intervention. So I have a very strong collaboration with First 5 YOLO, and one of the programs they have is a nurse home visiting program called Welcome Baby. And a nurse visits the home within 1 to 2 weeks postpartum. And so they do a comprehensive physical assessment, they do mental health screenings, they do not just COVID-19 immunizations, but making sure that the birthing person, but also any other children, and or even if there's a partner in the family, that they're all up to date on their vaccinations. They do education, they do lactation. It's a very comprehensive program that those families, depending on how at risk they are for poor outcomes, can continue to be followed with other programs. So First 5 YOLO has had amazing reach. So they've engaged 9 medical systems so far. In the first year, these are just first year data, they enrolled 519 families, and then 252 of those families had their infants, had their babies, and had home visits. They also reached a very, very diverse clientele. So you can see here the vast majority of the folks identified as Hispanic or Latina, and really about 10% identified as white, and the rest, again, were people of color. So really reaching those high risk groups. But I want to point out some really impactful things because this comes back to prevention. So we compared what Welcome Baby did to what Medi-Cal patients in general, how they were doing on their postpartum visits. And what you can see is that depending on what we were looking at, whether it was, a first, being seen within the first couple of weeks or their 6-week visit and having at least 1 visit versus 2 visits, you can see that Welcome Baby participants had rates of postpartum visits that were 2 to 3 times higher. That means that those women were able to get screened postpartum. So there's some people think that you're only at risk for pregnancy complications up until you deliver your baby. But in fact, people can develop hypertension, people can develop preeclampsia and eclampsia up to 6 weeks after having their baby. So this was a key intervention point. We also had amazing success with well child visits. So the first month visits were 9 times higher compared to Medi-Cal patients in Yolo County, the 2-month visit 3 times higher. And then the having at least 2 visits by the time the infant was 6 months old was 1.7 times higher. So we had some great success with getting those infants seen, which means, again, they're getting their preventive care, they're getting screened, they're getting immunizations. Moving on to health screenings, First 5 YOLO is part of a Yolo County trauma-informed network of care that we developed. And these are some, not all. We have up to, I think when we sort of sunsetted with the follow-on grant, we were at about 36 organizations that were involved in the network. But this was a partnership that we had, and we received almost $3 million through the Office of the California Surgeon General, looking at adverse childhood experiences. And as you recall, adverse childhood experiences are associated with cardiovascular disease later in life. So the goal was really that we wanted to educate our community on what are ACEs. Why are we screening for them? Why does this matter? We also wanted to increase the number of screenings for ACEs. And so this is both, really all comers, children, adults, pregnant people, screening them and referring them to appropriate services based on their screenings. Again, the family education, adoption of a shared referral platform. This was an extreme challenge, but we got folks to agree to this is how we're going to communicate when we refer patients. Community engagement around trauma-informed care. So we developed very many kind of communication modalities with our community leadership board around ACEs, around trauma-informed care. And also we provided support for providers in order to minimize burnout. As if anybody has been a provider or is a provider on this call, you know that working in populations that have limited resources is extremely trying, it's stressful. And then we've added on, screening for adverse childhood experiences. And so that can be very stressful and increase burnout rates among providers. And so we did a lot to support and create structures for providers when they were feeling, challenged by some of the work. So let me tell you, out of all this work, what the impact has been. So first of all, our collaboration with First Five, Welcome Baby, we, as you saw, had better adherence to recommended postpartum and newborn care. I didn't share these slides, but increased breastfeeding, decreased prenatal weight gain, improved weight loss after pregnancy. Perhaps more importantly, we saved lives, literally. So this program saved lives. There were infants who were referred to emergent care where the physician said, had the home visiting nurse not referred that child, that infant, they likely would have died. We had mothers who had postpartum preeclampsia, and they were, again, referred in a timely manner so that they did not have a poor outcome, did not die, but actually got the care that they needed. And we also have been able to share these data to show the value of this to funders like the partnership, which is the Medi-Cal HMO that covers Yolo County. We've also improved clinical pathways. So the federally qualified health centers that participated in our network of care, they developed all new pathways for clinic visits, and it enabled them to increase ACE screening and increase referral to support services in a way that they weren't able to do before. At the same time that those clinical pathways involved educating patients. And so we were able to kind of take the burden off the provider, give the patients more information, education, and then use those data to provide just more personalized care to patients. We've also built incredible capacity to innovate, implement, and evaluate new approaches and to apply for funding. So we have very detailed data use agreements. We have agreed on a shared data abstraction method that ensures patient privacy, but also allows us to obtain key outcomes data. And we've effectively applied for multiple different externally funded grants from various sources, including the state, including a couple from the state, including federal funding. So we've really created a system that allows us to kind of keep building on the work. We've also developed some very interesting mobile applications. We have the GROWA application I talked about. We have another one that's built off that's Empowered, called Empowered, that provides kind of education and then information on how to increase physical activity when your resources may be limited and your time may be limited. We also developed an ACE education and screening tool, and all of these tools are available for no cost and broad distribution so that we're actually able to make them accessible to folks with limited resources. And then, the community engaged priorities, projects, outcomes dissemination, I just can't speak more highly about how that really supports the work that we do. So again, we pay these advisors, and they help us consistently, they ensure that the tools that we're using, the videos we create, the handouts we create, the applications we're creating, they ensure that as a consumer themselves, as someone who would be using these tools or reading these handouts or potentially being asked to participate in a research study, they can say like, I like this, I don't like this would turn me off, that's too complicated. I can't express the degree to which they have truly impacted our work, and the importance of us continuing to pay them and to recognize the value of their lived experience and how that really just impacts our work in just ways that can't be measured. And it's really changed how we've approached the work. So how can you get involved? Well, a lot of what we do is expensive. We try to like train students, graduate students, undergraduates, postdoctoral trainees. So that's a really important part of what we're doing, because it's not just about what we're doing now, but it's about training folks to continue that work, um, you know, for the next generation and the generation after that. Project funding, supplies, paying for participants to give us our data analysis, getting biomarker data and analyzing those data. Lots of opportunities to support funding, community engagement. So stipends for our community leadership board members. So that we can continue to engage them and to get that feedback that is so critical to making sure what we're doing matters to the folks we're trying to have it matter for. And then community education advocacy events. We hosted a birthing justice kind of event screening and town hall. I guess it was a year ago, April now, and it was a great success. We were able to bring folks in from the community and really talk about maternal morbidity and mortality and ways to address that as a community. So sponsoring more of those events is so helpful. And then also participate with us. We have a newsletter that comes out that tells what's going on and opportunities, and also join us. We love having folks come in. You don't have to be affiliated with UC Davis in any way. You can join us, come to our meetings. We have amazing talks about once a month during the academic year. We ask people for ideas so we can, get community ideas about research. We're always excited to have people join us. And that's what I have for you today. Questions? And I'm going to stop sharing my screen.
Thank you so much, Dr. Simmons. Incredible presentation. And we do have a few questions from the audience. First question is, how do you work with pregnant and postpartum women for purposes of research?
Yeah, so we do a few things that I think are really kind of unique and innovative. One of which I spoke to, which is we get feedback. So we don't try to just go out and say, hey, we're doing this research study, but we really do get feedback. We're very mindful about that people are giving us their time, they're giving us their lived experience, they're giving us sometimes their date, their biologic data, their DNA, right, in some studies. And so we really kind of engage, and I would call it kind of like pre-test, like this is what we're proposing to do. If you were to be on the receiving end of us asking you to participate in this, like, how does this feel? How does this look? What would you like to see differently? And then, in terms, once folks are actually engaged, it depends on what they're doing. Maybe they're on the community leadership board, maybe they are, an actual participant in a study. So again, it depends. It could be remote. Grow was totally remote. We never actually met anyone face to face. Sometimes we're in the clinics and we're recruiting. So it really depends on what we're actually, what the research is that we're doing or the outreach that we're doing. Oh, you're muted.
What is so unique about your community leadership board? I know you touched on that. So why is that so critical for you?
Well, I think one of the biggest things is that we pay them. Paying folks on community leadership boards has been a source of frustration. globally. There are just various structural barriers to it. And I think for a long time, there was this kind of idea that we shouldn't need to pay them. And that's definitely changed. And I think folks who really work in the space agree that those folks need to be paid. But so we pay them. They also are experts in their lived experience and their experience with the community-based organization or the federally qualified health center that they've been receiving care from. So some community boards are made up of, like CEOs or executive directors of community-based organizations. Every member on our board, our community leadership board, is a patient of one of the clinics that we work with, or they have, they're a client, they've received services from one of the organizations. So they have really lived like in these spaces, and they have received services in these spaces. And so they come at it with this is what worked, this is what didn't work, this is what I would have liked to seen better. And they're just so brutally honest with us, which is wonderful. The other piece is we have a community education coordinator, Jasmine Cuellar, and she's the person who actually interfaces with them. So if we have a question, she will, we will sit down with her, but she will bring it to them so that they aren't feeling the power imbalance from us. That, so they're not afraid to say that's a terrible flyer, or this video is horrible. It makes me feel bad, and I don't want to come into the clinic and feel bad about this thing you're trying to educate me about. So I love that we take that away. We take that out of the mix so that they're very, very keen to tell Jasmine all kinds of things. And it's been amazing.
That's so important to have feedback from people you serve, from patients that you serve. So, and for the sake of time, I'm going to ask a couple more questions and then we will wrap. But what is the pod sitter's plan? So, 5 years, not a detailed plan, but sort of where do you see yourself going in the community, and why is that important?
Yeah, I think our goal is, we do write a lot of grants. Grants are getting harder and harder to obtain, but we really want to have a center like a center grant. I think that is sort of the next kind of big thing, and there are some venues for that, but to really be able to kind of financially sustain the infrastructure we've created. So it's not free, right? The infrastructure we've created, like the positions we have that serve as the facilitators, like that is all human power. And so we really, I think, just sustainability. I mean, that is, and having a grant, but also, I would love an endowment. That'd be amazing. But something, right, that would keep the work sustained so that we can keep doing it. We're not worried about, oh gosh, this person's on this grant and that's running out. So now we were trying to problem solve, but a little bit more of a better sustainability model. And we're still, I feel like in terms of organizationally, we're still pretty young, and we 6 months into kicking off was the pandemic. So I kind of don't count those years a little bit. So I would say we're still in our nascent development. So we've got time.
And how do students and other trainees get involved with Pod Center?
Yeah, so we have many faculty. They're on our website. So we host every month, like I said, during the academic year, we host talks and we invite experts, but we also invite trainees to come and present their work, which is great. But the trainees can interface with the experts we bring in from the outside. We have different research assistant opportunities with different faculty who are affiliated with the Pod Center. Some of them are for undergrads, some of them are for grad students. It really depends. And I think all the folks who are in the Pod Center are very good about like if a student participates, like you get to be on a paper, we really try to build up that academic CV component, but also we've had students who've gone on to work in, like we have students who work at one of our federally qualified health centers as employees now. They're social workers there, or they're, patient navigators. So that's also been really neat to see, they've learned and come to love these organizations, and then they graduate and go work there.
Incredible to hear that the impact of this program is spreading throughout, even outside of the walls of what you're doing. And I have another question. Is the Surgeon General of California still interested, involved in supporting POD?
Oh, that's interesting. So this was the first Surgeon General, who was also a UC Davis graduate. So she was the first Surgeon General for the state of California. And so ACEs, Adverse Childhood Experiences, the ACEs Aware, that was her campaign. Diana, the Surgeon General who has taken over from her, still has interest in ACEs, but so the grants that came out, we were recipients of both of them. So we got that initial, almost $3 million, and then there was $1 million follow-on that was called a practice grant that came out of that same initiative. And then the expectation for that was actually that the federally qualified health centers would be the primary. So for the initial one, UC Davis was primary. The centers and community-based organizations were, co-investigators with us on the practice grant. RFQHC was primary, and then we were secondary. And so in terms of that, I would, and then we got like a COVID grant that came from this kind of a combo. UCSF managed it, but these were state funds too. So we definitely have applied for funds in terms of just like the state saying, here you go, Pod Center at UC Davis. No, we haven't gotten that, but we definitely go for, we do apply when there are calls that come out of a DHHS or the Surgeon General's office that apply to what we're doing.
Great question. So if there aren't any other questions, at first I want to express our gratitude to each and every person that took time to connect with UC Davis Health today. Truly the impact of UC Davis Health and Betty Irene Moore School of Nursing is amplified through philanthropic support. Whether your interest is in supporting patient care, research, or educating the next generation of scientists, physicians, and care providers, we're ready to assist you in aligning the impact of your gift with UC Davis Health, the world, and beyond. Please contact me if you have further questions about our conversation today, or you're interested in supporting UC Davis. And Dr. Simmons, thank you so much for taking the time to join us and share this valuable information with our audience. I have learned that I've run 4 Ironmans. That is great information for me. And thank you again. We look forward to connecting with everyone.
Thank you so much.
Great day.